Good morning, everybody, and welcome to the orthopedic session. We have a packed schedule on a very important topic. We have speakers from many facets of medicine and the allied health professionals, so we're very excited to get started. Both John and I have decided to introduce a patient to set the tone for the meeting, and I think that the interview that I conducted with her hits on a few themes that hopefully we'll come to address in our Q&A. What we might do is we'll do Q&As after every three speakers or so, and if you want to type your questions into the Q&A section, we'll be able to read them. So this lady, who is a patient of mine, presented with the sequelae of pediatric hip disorder and ended up having hip replacements under my care, which was not without its challenge, both for herself and myself. She still requires knee replacements, and she's a patient also of Professor Heneghan, one of our speakers. So we might start the video now, and we will talk thereafter.
It was quite challenging at first. I found it very difficult to walk and do things in everyday life. So I eventually got to you, but I went through 2 or 3 different people first to get to you, because with weight, the doors were nearly closed to me. I was literally told to go home and lose weight. And it's very hard to do when you're in pain and you're trying to get around. So I was delighted to meet you and go through everything. And you came up with a plan for me, and we worked together then with that plan, and here I am today, thank God, well able to walk and well able to do things in everyday life.
Tell me a little bit about how that made you feel when, as you described, the door being closed straight away.
Oh, like I went through 2 to 3 people first, 2 to 3 surgeons, and they told me to go home and lose weight, which I did do. And even going back, I tried my best, and when I went back, it still wasn't enough. And I didn't know, I felt there was no hope out there for me. I really felt, I felt devastated, to be honest, being told to go home and lose weight again, when it's very difficult, because you've no one to guide you in doing that, really, and that's where I was with it, but I was just lucky, that you came up with a plan, for like, say, exercise pool and things like that. There's nobody had said that to me. They just said to me, go home and lose weight and come back in a few months. And even when I did that, I didn't lose enough. But when I did go back, there was no plan put in place as such.
We took a bit of a different approach. We acknowledged that you weren't going to lose vast amounts of weight, and we focused a bit on strength and condition, but also on your mental health. We managed to find a counsellor for you and talk through things. Did that help in any way, or do you think you got most of your benefit from taking a strength and conditioning program?
Oh, absolutely no. You have to be mentally prepared to go and have the surgery, but to start on the plan, literally, both were very effective. The counselling, definitely, and obviously, the mind rules the body, and then the exercise plan was just super, because it gave me strength in every way. So it did, I absolutely live my life now every day by the pool, and that's it. The pool, I would recommend it to anybody that has weight. It's just something that I never thought of before, or wasn't even told, that kind of a way. So when you put a plan together and we did all this, I have not looked back.
Between your hip replacements, we left a good year to get ready for the second side.
Yeah.
Am I fair if I said that you got a bit complacent in between the 2 hips and fell off the wagon a bit in terms of your prehabilitation? Tell me a bit more about that and your post-operative course then after the second hip.
Yeah, it was very different. The first hip, I just seemed to have ran away with it. Yeah, definitely the time in between, as you say, I literally didn't look after myself, and that's the sum total of it. I really wasn't surgery ready. I wasn't mentally prepared, I suppose. COVID had taken effect in Ireland here. So it was a different rehabilitation after the second hip being done. But I got back into it. But it took a lot to get back into it. Mentally, I had to get back into it first, and then physically, of course. And now it's just part of everyday life, what I do now at the moment.
A lot of the counselling beforehand with me was about the risks that both you and I were taking on.
If they can't lose weight, definitely the bariatric route is the way to go. There's so much help there, but it's just not, I suppose, advertised enough in Ireland. And I suppose the Irish nation have a very different look on bariatric surgery than they would anywhere else in the world. So definitely between that and definitely counselling and the help of the pool, as I say, I keep referring back to that because, as I say, it's my life at the moment anyhow.
Yeah.
And I would not be able to walk only for it, you know.
Yeah, unfortunately, some people are nervous of the water, so that's not an option for everyone, is the challenge that I think we face when we're counselling patients. Would you have any advice for doctors on how we, and other healthcare professionals, and how we manage not just the communication, but the general overall management of people with increased body mass?
Well, as a patient and after being there, I suppose really the approach that you take to a person coming in to you, you know, it's a very delicate situation, or people's mind, you know, when they have a BMI like me, you feel very uncomfortable even walking into a surgeon, and you know that you have work to put in, but it's just the approach the surgeon takes, as far as I can see. As I say, I've been with 2 or 3 before you, Mr. Rowan, and when I went into you and you told me that yes, you would operate, because I got so many no's, it was such a huge relief, even just for that, to hear that yes, you would work with me and do the surgery with me. Because for so long, as I say, I was told to go home and lose weight, and that was it, end of story, you know. So I suppose the approach, basically, if a person comes in, you know, to make that plan like you did with me, you know, and then it's teamwork after that then for both the surgeon and the patient, you know.
You found a very good therapist as well, a physiotherapist close to home. How was your relationship with them?
Yeah. Oh, fantastic. She was absolutely brilliant, so she was. I couldn't recommend her highly enough, you know. And there's quite a lot of people, as I say, yes, they don't swim in the pool, but they walk in the pool every other day with me. People that have joint complaints, they can't swim, but they certainly walk in it to help themselves.
So I'm going to thank you very much for your time. We're going to move on to the rest of our speakers this morning, but certainly I think you've set the tone for us. So I'd have to thank you very much on behalf of myself, Professor O'Byrne, and the rest of the attendees this morning. So I think we'll go straight into Donal O'Shea's talk, and I might just remind both viewers and participants that there may be members of the medical press as well as patients on the portal.
Good morning. So I'm sitting with Helen Heneghan in her office, and she follows me. Thanks very much for the invitation to speak, and thank you, Fiachra and John, for kicking off with the patient's voice, because I think that really does need to frame everything. Just going to share my slides. So I'm going to talk a little bit about the model of care, but before I do that, the story we've just heard this is what's happened to obesity over the last 30 years. The body mass index over 30 has doubled. The body mass index over 40 has gone up 600%, and the body mass index over 50 has gone up 1200%. So we have an explosion in that extreme end of the spectrum of people living with obesity. If you tell somebody who's obese, as our patient reported there, just go home and lose weight, that's what happens. If you say exercise and lose weight, you'll begin to see a little bit of a change, 1 to 2%. Diet and exercise allows you to achieve 5% weight loss. If you choose a more extreme dietary approach, you can hit 10%. But 90% of patients with lifestyle change will not get more than 10% weight loss. So do not tell somebody who's living with obesity to go home and lose weight. Signpost them to supports that will give them nutrition and physical activity approaches that will work for them, and give them realistic targets. The analogy that I use when I'm talking with the healthcare providers is the malignant melanoma advice. This is Bondi Beach in 1970. If you took a picture now, there would be a lot more obesity. There would be a lot more devices and heads in phones, and a lot less heads looking at each other and conversing. And there would be a huge amount more of sun protection. So you get melanoma because you have a genetic predisposition, and you get too much energy from the sun for your genes. There's lots of people get a lot more sun and don't get melanoma. We don't tell somebody who has the disease of melanoma to put on sunscreen and wear a hat is their treatment. We would be struck off the medical register, and rightly so if we did that. You develop obesity because you have a genetic predisposition, and you get too much energy from the environment for those genes. There's plenty of people consume the same amount as me and are living with extreme obesity. So we still tell people to go home, eat less, move more as their treatment. It's not acceptable. It's not backed by the science anymore. Prevention is different from treatment. So do you need to do the prevention piece when you're managing your melanoma? Of course, you wear your sunscreen and you put on a hat. And for your obesity, of course, you have a physical activity approach and a nutrition approach to support the treatment. But we need access to the treatment. My job is to talk about the model of care. And the model of care for obesity, we have one for adults and children. I'll show you the children's one, but I'll focus on the adult one. And our model of care aligns with the Sláinte Care integrated framework for prevention and management of chronic disease. And level 0 is living well with your chronic disease. And that involves, self-management support. It involves activities that are available in your community that you can go and do, women on wheels, men's shed, that kind of support. In general practice, it's all about detecting, identifying, screening and recording, and signposting if you've identified people with disease. And then level 2 is going to be in these community hubs. What kind of intervention can we deliver? And then the specialist care that people with severe and complex obesity need is going to be happening still mainly in the community, in specialist ambulatory daycare hubs, and the only cohort that will be going to hospitals are those really where consideration for bariatric surgery, inpatient rehab if it's needed, and possibly palliative input, which is better supported for obesity in other European countries than it is here. So this is the adult model, and I'll just talk you, level 0 is kind of the prevention and maintenance piece, and it's out in the community. GPs are now been remunerated for weighing and measuring and recording, so they're identifying patients, and if they identify patients with obesity, they'll be screening them for complications, and they will be referring them to a community delivered dietitian-led multi-component weight management intervention that will run across 12 months and involve 22 contact hours. That program has been developed, dietitians are being recruited. Recruitment is an ongoing issue for these multidisciplinary teams, but this is beginning to be rolled out in certain primary care units. There's 96 dietitians being recruited. They're going to deliver a diabetes prevention program as well as a weight management program. And then we're going to have 6 multidisciplinary teams, one in each of the regional health areas when they become that, or in the hospital groups, that will deliver a high intensity intervention, and based on how the patients do in that, they'll be referred up to level 4 for consideration of bariatric surgery. The children's service, I'm not going to go into just in the interest of time, but we do need a service for children with severe and complex obesity. But what we need is the development of 1A and 1B in this model, which is a community-based end-to-end management of children with severe and complex obesity. There are large gaps at the moment that we're trying to fill. There's a lack of national services at level 3 and 4 level. We're a ministerial priority, so we're hoping to press go on recruitment for level 3 and 4 this year and complete next year, but we have requested a meeting with Paul Reid because of lack of progress with, if you like, pulling the trigger on releasing of funding. And within children's, it's the same situation. There's very limited services, and we need to, recruitment is ongoing in the level 1A and 1B end-to-end model of childhood obesity management, and we need to pull the trigger on availability of services for children with severe and complex obesity, including modest access to bariatric surgery. And the patient journey is going to be, you know, through primary care screening, onward referral, either to level 0 or level 2, and then onward from there. And the landscape of how we manage obesity is going to be changed and transformed by the availability of pharmacotherapy, which again we're working with the HSE to make sure is available for patients with medical cards, not just for patients who can afford it. So the model of care is approved, it's only part funded, and unless we get surgery, the model just won't work. So thank you very much for your attention. I will pass over to Helen.
I'm just going to screen share screen.
Yeah. Like, Fiachra, do you want me to just keep going with?
Yeah, keep going. What we'll do is we'll stop after Niall's
Okay.
Niall's talk, because I think Colin mightn't be online, and we'll just maybe have a quick Q&A at that stage. So go ahead, Helen. Thanks.
Super. So again, thanks Fiachra and John for inviting me to speak about the orthopedic outcomes after bariatric surgery. I appreciate time for the talk is short, so I'm not going to, and the following speakers are going to give you an insight into how obesity impacts bone and joint disease. just to say that it does contribute to, there's some of this sets the scene for how bariatric surgery helps with this, as did Porgy when she spoke so eloquently about the impact of obesity on her pain level, but also the contributor to her joint disease. Obesity does cause soft tissue damage and contributes to degenerative joint and disc disease. In fact, it accelerates it to the point that patients with a BMI over 30 are 20 times more likely, for example, to require a knee arthroplasty than a patient with a normal BMI. But obesity also has negative impact on orthopedic surgical outcomes. It can increase operative time, perioperative, post-operative infection rates, but there's also an association with prosthesis failure or loosening of implants, hence why it is important, if feasible and possible, to help patients achieve weight loss before or after undertaking orthopedic surgery. That's not an easy undertaking, but bariatric surgery is the most effective treatment for severe and complex obesity, as Donal has said already. I'll begin by going, I have a joint-specific theme to illustrating the impact of bariatric surgery on orthopedic outcomes for you. I'll begin with joint pain, and there is plenty of evidence, although the evidence is mixed in terms of its quality, that support the fact that bariatric surgery improves joint pain. The best evidence I could find was a systematic review of 23 studies over the last few years. This was published just last year, that focused predominantly on knee pain, but included 9 studies that had also evaluated hip pain. Just to put it in context, the quality of this evidence is quite weak because they included all 23 studies were rather small. Many of them were retrospective, so there was a reporting bias in terms of pain pre and post. There wasn't always a prospective acquisition of data regarding pain pre and post-op. But nonetheless, it did. These studies did suggest that any weight loss does improve function and joint pain. Even 5% weight loss has been shown to increase physical function by 24%. Specifically with regards to knee pain, in this systematic review, the majority of 23 studies, 18 of the 23 studies, showed a significant decrease in both the frequency but also the intensity of pain. The data was less strong for hip pain improvements, but it did reduce significantly in 2 of the 9 studies. The other 7 studies showed improvements, but it didn't meet significant clinical significance when compared to the levels of pain and the frequency of pain patients had post-op. So it seems that bariatric surgery decreases knee pain more than hip pain, and didn't really, the systematic review didn't explore reasons why, but bearing in mind that people have lived with hip pain for a long time, and although they have bariatric surgery, they often remain with quite high BMIs, and a lot of the damage to a joint, for example, is already done, and that won't improve. There's also evidence to look at overall physical function and bodily pain, other than just a joint pain. The best evidence for this is from the lab study. The lab study is a longitudinal assessment of bariatric surgery, one of the best prospective bariatric studies that we have, that looked at bariatric surgery patients in 10 US hospitals between 2005 and 2010. There was 2,000 data from almost 2,500 patients recorded. And they assessed many metabolic parameters, demographics, and everything, but they did actually include physical function and indices assessing the severity of pain from osteoarthritis. And they assessed these both pre-op, but at 1 year and 3 years after bariatric surgery. And in these near 2,500 patients at year 1 post-bariatric surgery, which was predominantly sleeve gastrectomy and gastric bypass procedures, there was a significant improvement in physical function in 76% of patients, walk time improved in 60% of patients, and body pain in 57%. They also looked at joint-specific outcomes, and again, this demonstrated improvements in hip and knee pain in 75% of patients. And 2 years later, so when patients were 3 years post-op, most of these benefits persisted to the exact same level as at year 1, but there was a slight decline in the improvement in body pain from 57% of patients reporting an improvement to just 49%. So there was some recidivism with regards to bodily pain. It isn't too surprising, again, given that patients still remain with challenges with mobility and overweight. Again, looking at, I'll move on to where orthopedic surgery has been performed. What's the evidence for bariatric surgery improving or changing joint arthroplasty outcomes. Again, the best evidence supporting or demonstrating a change in orthopedic surgery outcomes after bariatric surgery was a literature review last year. It wasn't possible to do apply systematic review methodology to the data because it was too heterogeneous and some of it was of poor quality. So again, bear that in mind in interpreting this, but nonetheless, they looked at 13 studies that had looked at outcomes of knee and hip arthroplasty in patients who had bariatric surgery. And the majority of the 13 studies, the take-home messages from this paper was that bariatric surgery certainly does decrease the uptime and length of stay compared to patients who had the same degrees of obesity and hadn't had bariatric surgery. It also was shown that patients who had bariatric surgery and then had arthroplasty had a lower risk of post-operative complications. And bear in mind, bariatric surgery improves metabolic health, and so ultimately you're operating on a healthier patient, perhaps with better glycemic indices, better blood pressure control, better lipid profiles, less sleep apnea. So they're overall a healthier patient to operate on, hence why they have a lower risk of lower respiratory tract infections, surgical site infections, cardio and cerebrovascular events, and most importantly, they have a lower risk of thromboembolic events, particularly DVT, but there's also evidence that there's less PEs in patients who have lost weight through bariatric surgery before arthroplasty. And that applied to both knee arthroplasty and hip arthroplasty. And then finally, bariatric surgery does lower the risk of reoperations after, specifically after hip arthroplasty. The data didn't suggest there's a lower risk of revisions after knee arthroplasty in patients who had bariatric surgery. But with regards to hip replacements, there's a 3-fold decrease in unexpected return to theatre and a 5-fold decrease in the need for revisional surgeries in patients who had bariatric surgery compared to patients with obesity who haven't had bariatric surgery. It seems like the optimal time, if you're going to take a concomitant approach and do bariatric surgery and a joint arthroplasty, that the benefits of bariatric surgery that I've just described apply when your patient is about 2 years out. So when they've been allowed to have time to attain the benefits that we see after bariatric surgery, not just in terms of weight loss, but also in terms of health gains. You might ask, is it cost effective to do 2 expensive operations like a bariatric operation and then a joint arthroplasty? And this has indeed been looked at, admittedly through Markov modeling rather than through real world patient data. But even considering the additional cost of a bariatric operation, this is a US study, so the cost attributed to bariatric surgery is about 23 or 24,000. But it is cost effective. So if you look at the ICR, the incremental cost effectiveness ratio for both procedures compared to just a knee replacement alone, it is cost effective given the quality of life that is achieved after bariatric surgery. So the ICR for both procedures together falls well below the $100,000 per quality willingness to pay threshold. So it's a cost effective approach to do both. There is evidence that bariatric surgery improves spinal surgery outcomes as well. So again, this systematic review published earlier this year only included 4 studies. It hasn't been looked at extensively, but nonetheless, it included 37,000 patients who'd had prior bariatric surgery and compared them to almost 150,000 people with obesity but no prior surgery. And again, there was almost a 50% decrease in overall complication rate in the group of patients who'd had bariatric surgery. That was specifically pertaining to renal, neurological and thromboembolic complications, all being decreased in patients that had surgery. But importantly, there was an almost 10-fold decrease in mortality. So 0.02% compared in bariatric surgery patients compared to 0.2% in patients who hadn't had surgery, and decreased readmission rates. So it seems like a really important intervention for decreasing overall complication rate and mortality. With regards to spinal surgery, there was no difference in revisional surgery rate, and these benefits applied for patients who are having cervical spine surgery and thoracolumbar spine surgery. So the benefits of bariatric surgery and orthopedic outcomes, I'll summarize soon, but just to say that they're almost all good, but there is an important caveat to this. We do know that bariatric surgery can have adverse effects on bone health, and I think it's important to mention that. We know that bariatric surgery can induce bone loss and it can lead to an increased risk of fractures. And there's multiple mechanisms proposed for this. It hasn't been well studied, but bone loss after bariatric surgery, specifically after any procedure that involves malabsorption, is because of changes in absorption of calciotropic hormones. So there's changes in gut absorption of calcium and vitamin D. Also changes in adipokines and in gut hormones can impact on calciotropic hormones, but also with weight loss is a mechanical unloading that affects bone mass density. But we are in multidisciplinary clinics quite good, I'd like to say, at preventing bone mineral loss, mainly through use of supplements and ensuring compliance with these. But to achieve good bone health outcomes, it's important to have a multidisciplinary approach to make sure patients are compliant with their daily supplements, which include a calcium and vitamin D supplement. They're encouraged to have pursue weight-bearing activity, and we've excellent physiotherapy input through our MDT in our weight management clinic to guide patients as to what that is. But we're not as good as we should be at the moment at compliance with DEXA scanning, but patients should have a preoperative DEXA scan and an annual DEXA thereafter to monitor for bone loss after bariatric surgery. So I'll end there just by summarising that bariatric surgery is associated with decrease in joint and body pain, an improvement in physical function, better outcomes after arthroplasty and spinal surgery. It is cost effective to do it, but we need to be mindful of the effects of bariatric operations on bone health.
Thanks, Helen. We'll go straight into Niall. Colin is online. So after Niall, we'll just maybe hit a few questions or highlight a few points while Colin is loading his slides. So we'll go straight into Niall Moyna now, please. Thanks.
Okay, folks, good morning. First of all, I'd like to thank John and Fiachra for the invitation. And I think importantly, we're now living in an era of evidence-based medicine. So the focus of my presentation will be to review the evidence for the role of physical activity in the treatment of obesity. Obviously, get this to move, here we are. Body weight is ultimately determined by the difference between the number of calories that we consume and the number of calories that we expend each day. And as we all know, in obesity, caloric intake exceeds expenditure for an extended period of time. So physical activity, we all know, contributes to total daily energy expenditure. However, basal metabolic rate and the thermogenic effect of feeding, they contribute as much as 75 to 85% of our total daily energy expenditure. However, both basal metabolic rate and the thermogenic effect of feeding are pretty stable, whereas the contribution to physical activity to total daily energy expenditure can vary greatly. In fact, it can vary anywhere from 10 to 35 to 40% per day. So the current model, the energy balance model, it posits that if we increase our daily physical activity, because that's the one that we can change the most, we're going to increase then our daily energy expenditure. That will result in a negative energy balance and result eventually in weight loss. So this is referred to as the linear model of total daily energy expenditure. And it logically assumes that as we increase our levels of total daily physical activity, there's going to be a corresponding increase in total daily caloric expenditure. And if we think about high levels of total daily energy expenditure, hunter-gatherer societies are a wonderful reference. This photograph shows the Hazda tribe who live in northern Tanzania, and they have a healthy weight over their lifespan. Not surprisingly, both men and women, Hazda men and women, are extremely active on a daily basis. There's no Sabbath, there's no weekend. They are active every day, 365 days of the year. In fact, on average, they are about 5 to 10 times more physically active than people living in Western society. The average Hazda woman walks around 13,000 steps a day, and the average Hazda man walks around 19,000 steps per day. And oddly enough, it wasn't until 2012 that the first study to actually measure total daily energy expenditure in a hunter-gatherer society using what we call the gold standard method of doubly labeled water technique. It was 2012 before this paper was published, and it collected data on the Hazda. And this is what they found. After controlling for lean body mass, because we know energy expenditure goes up as people get larger, more cells, we've got to look after more tissue. What they found that there was no significant difference in total daily energy expenditure between those living in the Western world and the HASDA. Even though the HASDA are 5 to 10 times more physically active than we are, they expend the same amount of calories per day. Now that goes against obviously conventional wisdom. So what is going on? To try and explain this, I've taken this study, and hopefully this will help get us to the mechanism as to what's going on here. This was a study published back in 1992. And what it did, they measured total daily energy expenditure in individuals who were sedentary and had agreed to undertake a training program in order to run a half marathon. And as we can see, there was a progressive increase in the minutes spent training per week over the 6-month period. And not surprisingly, energy expenditure increased during the initial weeks of training, and the expected increase here is shown in red. However, the observed changes in total daily energy expenditure in response to increased minutes of physical activity was the opposite to what they expected. And in fact, what was happening, seemingly, the body was dynamically compensating for increased levels of physical activity. Somehow the body wants to keep our total daily energy expenditure within a very narrow range. And if you start an exercise program, so here's an individual here, and this is in this part here, we see that their contribution, sorry, they're sitting here. There's a relatively sedentary individual, they're sitting here, and this is all the rest of their energy expenditure in the total day, very similar to the first diagram that I showed you. So when these individuals, whether they're sedentary or obese, when they initiate an exercise program, they're obviously going to get an increase in energy expenditure in the immediate term, because exercise is not free. You have to burn calories. There's a cost to exercise. But what happens, we get this dynamic compensation that occurs that tries to keep our total daily energy expenditure in check. And this can occur within days to weeks. So what we have here initially, we have this big increase in total daily energy expenditure. But because of this compensation, what we do is we start to spend less energy on the other parts. And really it makes sense, because when we go from being sedentary to active, there's less chronic inflammation. We're less insulin resistant. We're not producing insulin all day. Our immune system is less active. We're less stressed. There's less activation of the hypothalamic pituitary adrenal axis, the sympathetic nervous system. We produce, for example, less reproductive hormones, testosterone and estrogen. So in fact, what we do is we spend less energy in this other system because we're actually healthy. And this reduces our risk for chronic diseases. And we refer to this as the constraint model of energy expenditure. And this model posits that humans possess a set of evolved mechanisms to maintain our total daily energy expenditure within a very narrow range. So what happens with lifestyle, particularly activity, lifestyle changes that affect physical activity will positively impact our total energy expenditure until this compensation starts to occur. And it starts to occur within weeks to months. And that's why we see this plateau phase. In fact, Donal's first slide was a perfect example. He showed how exercise went down, but then it started to come back up again because we start to dynamically compensate. So in the long term, physical activity will have little, if any measurable impact on our total daily energy expenditure. So in effect, maybe we're looking at the wrong end of the equation. And this is obviously a totally different story. Caloric intake is the big issue. And it's a multi-trillion-dollar industry. And in the food that we're consuming is playing an enormous role. And really, if we want to tackle obesity, obviously activity is important, but the major role will be in caloric intake because of this dynamic compensation that we have. Now, it would be remiss of me as an exercise physiologist not to mention, the important role of physical activity in both our physical and our mental health, because both acute and chronic exercise impacts every single organ system in our body in a positive way. And it does it during every stage in life, from the very young to the very old. And I should state that there is obviously clear evidence, and you're all aware of this, that exercise and physical activity does play a very, very important role, though, in weight loss maintenance. Thank you.
Thanks, Niall, and thanks for keeping the time. While Colin Dunleavy is loading his screen there, I have a couple of questions that have come in for Helen and Donal. I'm not sure if you can see the Q&As there, Helen and Donal. I'll read them out to you. The first question for Donal would be about I suppose the different types of patients with obesity, the patient who is genetically predisposed to it, and then the average person who has eaten too much over COVID, for example, or over Easter. Is there a social responsibility and I suppose a governmental responsibility to encourage people to maintain their own body mass and then reserve, if you like, the finance of healthcare for the patients who are genetically predisposed? Donal, if you can follow what I'm asking.
Yeah, so we're all, the genetic, so there are a very small number of rare monogenetic causes of obesity, but there are many hundred genes that have been identified that lead to the population obesity that we have, and there is a social and political responsibility required and some personal responsibility to encourage and make the healthier choices easier and not let the food industry run away with it. But we need a big attitude change to people living with obesity. So at the school's hurling final on Patrick's Day, one of the players was living with obesity, highly skilled 17-year-old. Every time he got the slitter, "You fat bastard, ha ha ha," chanted. Not one bit of action taken. Now, the GAA have anti-bullying policies, they have anti-racism policies. If it had been "you black bastard, ha ha ha," it would have been all over the place. And somehow it is acceptable to say it's your fault. We have a genetic predisposition, we have pregnancies, we have drugs that cause obesity. It's multifactorial, and the majority of the factors are outside of the individual's control. So there needs to be an attitude change.
Okay, Helen, the demand for joint replacement in this country is high, and I suppose it's a manifestation of the low consultant to patient ratio in orthopedics, like in all our subspecialties. There clearly needs to be more bariatric services, perhaps not all more surgery. Where does the money fit into this? If I can do a hip replacement and take on some risk on 10 patients that perhaps maybe would use the same amount of time to do 2 patients for the bariatric service, not perhaps the surgery length of time, but all that entails. How should we balance out that financial aspect?
Yeah, I suppose, aside from looking at the combination of arthroplasty and bariatric surgery costs, like bariatric surgery is one of very few operations that are cost effective and save the health service money, because treating obesity is really expensive. So even just saving on medications alone that patients get off within a year after surgery, and for the most part would stay off lifelong, and pays for several surgeries over a patient's lifetime. Like, we're not doing enough here. Donal alluded to model of care having a few gaps in terms of funding, and the biggest gap is for bariatric surgery funding. Like, it's only currently funded to quite a small level in our hospital group, and we're doing about 100 a year through the Loughlinstown programme, and roughly about the same through Vincent's private as well. But that's, I mean, that's at least 6-fold under the very bare minimum that we need to be doing around the country. In fairness, the Department of Health, I suppose, and HSE have committed to, verbally committed to funding 1,200 surgeries, bariatric surgeries a year around the country across 3 centres. you know, in terms of getting up to that number with no promise and delivery of programmatic funding, like we can't move forward from where we are. That has translated into us having a 5-year wait even to get into our 4.5-year wait to get into our clinic. So if you refer someone now with, you know, severe pain because of joint disease or for whatever reason, and although we try and triage people, well, the volume is so big that actually there's still a long wait before patients get their first visit. So first visit from referral to surgery is still about 6 years because of the excessive demand compared to supply at the minute, and that can only change with programmatic funding.
A question for Niall. You're the group that you used to illustrate your point that has the people. Is this not just simply a smaller genetic pool as opposed to a diverse multicultural New York City or Chicago? Is this not really what you're saying? Is that not just reinforcing what Donal's point was?
Yeah, obviously there is a genetic environmental interaction with obesity, but those results have been replicated in other hunter-gatherer tribes. For example, the Swar in Ecuador, very, very similar. And interestingly, in that study, they took children, and what they showed that Swar kids living in rural Ecuador versus those who go to the towns versus kids in America have the exact same total daily energy expenditure. However, the kids in America have an average percent body fat of 26, and the Swar kids living in the rural Ecuador had a body fat of 12. So that the total daily energy expenditure, one is a body percentage of 12, the other of 26. So total daily energy expenditure is the same. So obviously it seems to be that the food environment is playing an enormous role. And obviously there is a food genetic interaction, and there are people who are more predisposing to developing obesity, particularly a PUD, in an environment where they're exposed to certain types of foods.
Okay, thanks. There's a few more questions which we might leave till we've had a few of the orthopedic speakers. Now we'll move on to Colin, then we'll go to Stacey, then we'll go to Colin Murphy, then we'll do Adrian, and we'll take a break there after that before we move on to the other orthopedic subspecialties. So I'll ask Helen and Niall just to close your videos and mute, and we'll let Colin Dunleavy take over.
Thanks, Speaker. Thanks for inviting me, and thanks for previous speakers. The painful truth will, I suppose, bring some of those points together, because this talk maybe isn't as much about nociception as it is about maybe letting go of some of our myths and some of them that Niall talked about already, discussed already now. There we go. So we'll take a typical patient journey, just like you introduced it at the very start, Fiachra. I thought that was very helpful. This lady who came to our service has always been overweight or living with obesity since early age, tried everything, very frustrated, developed back pain, knee pain, typical of our patients, at the end of a tether, wants to have a baby, running out of time. So we already know she is lived in a psychologically stressed situation, which unfortunately does seem to add to the disease of obesity itself and accelerate it. And people who are in that situation, they just by that psychological loading are much more depressive in their approach to life and to managing things, which actually makes it harder. And when we come to physical activity and exercise, it's actually harder to adhere to those. So things are harder. Now, she believes she can't tip the seesaw. We saw that seesaw that Niall introduced already, kind of oversimplistic, and then we know that based on things like the Hadza tribe, etc., that just does not work. That is not a valid way to approach this problem. Eat less, move more, and that's one of the first painful truths to this situation. Accept it or not, that's the way. It just does not work. So obesity isn't the choice that she's made. It's not a character flaw. It's not her fault. It's not because of greed or too much calories. That comes later. That's not the first problem. She's not lazy. It's not helped by shame. And she shames herself, and she's constantly shamed when she seeks help from us, as in healthcare professionals. And there's not a reason of stigmatizing this problem. It does not help. So we need to stop doing that. It is a genetic problem and a genetic environmental mix. And with that's pretty well understood at this stage. So it's not in doubt. And if we want to go back to that outmoded model of the seesaw, we can just shift the focus or the fulcrum of the seesaw, because that's actually what's happening. the scales or the seesaw is working against her. And that's a genetic issue. And she knows this. When we explain this to her, she goes, yeah, well, that does make sense, because I have my lean friend who can seem to eat way more than I eat. And she doesn't do any exercise, and yet she's lean. And I have to look at half food that she consumes, and I'll put on 5 kilos. So it is not just about the calories that are around. It's the way the calories affect her, and they affect her differently than her friends. Lee Kaplan, a couple of years ago, described this very well, and this model of homeostasis that we accept for everything else in health and our physiology, that there is in fact a defended weight homeostasis, an internal clock that our body wants to get to, or a kilogram measure that it wants to get to. And we think that there are certain environmental factors that seem to trigger that and push that up. And once it gets higher, it doesn't really want to go lower again. So it isn't not that it's not such a malleable issue for the body. We certainly try, that conservative approaches to lifestyle management, healthy diet, regular physical activity, pain management, rehab, stress management, getting our sleep right, getting our relationship with food, and maybe getting our medications right. They seem to help, but you've constantly got those red arrows pushing up all the time. Niall already talked about the studies and around the total energy expenditure and this concept of creating a negative balance, a negative energy balance, and that we'll lose weight, but that doesn't actually work. And this is what she believes, because she hears it all the time. And just move more and work harder. And she's tried all that, and she's burnt herself out doing it. And we know that it doesn't work. So we explain it to her that doesn't work. The interesting thing about the compensation model that Niall talked about was that it seems there's even more compensation for those, almost double the amount of compensation with the basal metabolic rate for those living with obesity than those without. So whether that's a factor of obesity or a genetic component that disadvantages them, we're not sure yet. But that's a well-established fact now. So it has nothing to do with just HADS. This population was across Europe, nothing to do with HADS or anything like that. This is a physiological truth. So a little bit about nociception. So she has back pain, she has knee pain, moving miserable, and I'm really worried about my future, because every time I go to see somebody, they say my bones are, my joints are bone on bone and they're crumbling and are very unhelpful, difficult imagery in our head to deprogram. And this is such a common thing. So this is from our patient group. We know that 91% of people have chronic musculoskeletal pain and multi-site pain at that. So it's based on nearly 1,000 individuals who attended us. And how that affects somebody in their weight management, we know also from several studies that those people who are in more severe pain find it harder to have any impact on their kilogram weight. And that's from another study on the same thing within a service just like ours. However, we know also that we can improve musculoskeletal pain with things like motor control, strength and conditioning, getting a bit stronger, maybe taking some of the fear factor. The whole spectrum of pain management, from the psychology to the behaviours, is really important to get right. And we also know and we have to explain to our patients that it's not just because it's of weight. There's an inflammatory process going on. This looked at osteoarthritis in non-weight bearing joints for those living with obesity, and it was also there. So it's not just about a loading, it's a bit more complicated than that. I think everybody in the room accepts that. And then, well, what is the real reason? The real reason we use physical activity in obesity care is to preserve physical function. Obesity is a disease that erodes physical functions, takes their ability, their participation, their quality of life away. So we need to re-establish that. That will have some metabolic effect, but not that much. It really is important to get people to participate. People don't want to leave their house because of shame and blame, etc. And that cycle continues. And that's my last slide. Thank you very much.
Thanks, Colin. We'll go straight into Stacey. If you can load your pictures there, Stacey, thanks a million.
Good morning. I hope everyone can see that. Thank you very much for letting me talk. So I'm going to share my experiences of some obesity in spine surgery. I'm one of the consultant orthopedic surgeons in the matter, but I also work in Vincent and in Cappagh. So we have the interest of looking after a lot of these patients in both the elective and in the trauma setting. So obviously we've already heard today that
So Stacey, your slides aren't showing there. So what I might do is you work away on that, and I might put a question that has come in about the inflammatory nature of obesity, perhaps maybe to Donal or indeed Helen. This is a concept that we have to get our heads around. I suspect that it's not just load perhaps going through the joint, but the inflammatory aspect of having obesity. Helen or Donal, are you available to take that question?
Yeah, sorry, can you just, what was the question again?
So a question has come in there about the inflammatory nature of obesity. For somebody who wouldn't typically have perhaps an inflammatory disorder, when they have obesity, this creates a pro-inflammatory situation, I suppose, systemically. And one of the questions was, people who have degeneration of their hips and knees and their ankles, the main load-bearing joints, which is it? Is it the load bearing? Is it inflammatory, or is it a combination of both?
So, I mean, I think our last kind of 15 years of research has been about how obesity impacts the immune system and the inflammatory profile. As you develop obesity, you lose an innate part of your immune system that is required for responding to any threat, viral. The COVID-19 pandemic showed us that in the first wave. Tumor surveillance is impaired. Calming of inflammation is impaired. And the osteoarthritis that we see in people with obesity is only part load-bearing mediated. It's also compounded by that pro-inflammatory. You don't get Heberdin's nodes associated with osteoarthritis from weight bearing. So there is that systemic inflammatory process that's going on as well, and it's a fascinating area.
And similarly, I think, Fiachra, the time frame in which it improves after bariatric surgery, a lot of the pain associated with like joint pain, for example, would improve before a lot of the weight is lost. It's quite interesting that pain improves even by 6 weeks after surgery, when that would, to me, that suggests that it's the inflammatory milieu that's changed. Just like we see with diabetes improvement or remission being within 24 or 48 hours, other inflammatory conditions or metabolic conditions improve very quickly, including some joint pain.
Okay.
I think also on that one.
Sorry, Colin, just before you come in, Stacey, I might ask Colin Murphy to step in there, Stacey, while you're working on your tech issues in the background. If Colin Murphy from Galway can launch his screen, and then Colin Dunleavy, I'll let you finish what you're about to say.
Just that immediate effect, after you've had a procedure and be waiting for so long, that psychological load is lifting, and it has to be acknowledged that that's a part of the pain cycle too, I guess.
Yeah, certainly we haven't touched yet, maybe later on, about the psychological effect and maintaining mental health when you're a person with obesity. Okay, Colin Murphy, if you wouldn't mind kicking off, and then everyone else can mute. Thanks.
Thanks very much, Fiachra, and thanks to the other speakers, and thanks for the invitation today. So about 15 years ago, 3 different surgeons from 3 different continents published a very influential paper in the Lancet article called The Operation of the Century, Total Hip Replacement. And those of us who are in the orthopedic tribe were very pleased that we're able to contribute to such a successful and common operation. And it is common. So about 6,000 hip replacements are done in Ireland each year, and the modelling suggests it's going to increase 20% year on year, and it is very successful. If you state your goals as improving pain and mobility and restoring quality of life, we have a 90% satisfaction rate for it. So this is a very good operation. But the impact of obesity is also quite clear. The prevalence is increasing, and the modelling suggests it's going to get worse. And we know that there's going to be an increase of patients requiring hip replacements for and with obesity into the future. And this is a function of two overlapping Venn diagrams, with a larger area in the middle becoming increasingly problematic for it. What does it mean for the patient? Well, I thought it was very interesting listening to Porkin earlier on this morning. The patient comes first. They do have, as Fiachra just alluded to a second ago, these increased joint reaction forces, altered biomechanics, as well as the systemic and the inflammatory problems that lead to damaging cartilage biology. And it also leads to younger patients with end-stage symptomatic arthritis that will require a hip replacement. What does it mean for the surgeon? Well, it means we have a huge amount more patients knocking on our doors looking for surgery. We have younger patients coming through looking for surgery, and we have patients who are increased complexity looking for surgery. And this is a major challenge to our system and to our own practices. At a technical level, it means longer operating times. So each operation will take proportionally longer than non-obese patients. It's significantly more physically demanding surgery than for non-obese patients. And there's plenty of evidence to show that. And there's a lot more work-related injuries reported among arthroplasty surgeons, in particular those that deal with larger patients. So we do have to bear that in mind too. And for those of us that are in the revisions area of arthroplasty, it's going to mean more revisions and more complex revisions, because these joints don't do as well as their corresponding joints in the non-obese patients. So obese patients, we've heard, have higher perioperative complications, more anesthetic complications, longer hospital stay, poor wound healing, and higher rates of periprosthetic infections, dislocations, and early revision hip surgery. And really the twin curses of this are infection and loosening. So a lot of factors contribute to increased infection, prolonged surgical time, poor tissue vascularity, increased surgical exposures, compromised immunity, as well as inadequate prophylactic antibiotic dosing. Simple things like that all contribute to a much higher rate of infection. And in terms of loosening, there's a 30% risk of aseptic loosening within 5 years, and that's not good enough. We also know the risk of early revision is 4.7 times higher than their non-obese counterparts as well. And again, that's extremely worrying for us. However, the functional outcomes, as we've heard, for non-obese patients are often equivalent, or for obese patients are equivalent to non-obese patients. And we must remember that. But in spite of that, obese patients seem to be excluded from surgery, either because, as we have heard, surgeons decline to perform the operations, or, as it happens in the UK and the NHS system, the CCGs, these clinical commissioning groups, have these cutoffs that preclude patients being referred for an opinion for surgery. So what's with these cutoffs? And whether it's the hard cutoffs like the NHS have, at least they put it in writing, or the softer cutoffs where the surgeon will decide not to operate, this really stems from the fact that obesity is seen as a modifiable risk factor for surgery. And we know as well the cost of these complications for the patient, for resourcing in terms of bed day staffing, and the financial implications are huge. So really the strategy to cut off, I think, is based on risk reduction. And BMI of cutoffs at 30 are around. They're not common, but they're certainly there. But they're far more common for BMIs of 35 and 40. And just remember that in Ireland, the INO report published this year shows that 41% of patients in Ireland having hip replacement have had BMI of greater than 30. So you're talking about excluding a lot of patients from the opportunity of surgery if we introduce those. And what's driving all this, stopping patients having surgery? It is the risks of complications. We know from some fairly impressive studies that the risk of complications above a BMI of 45 significantly increases for any complication, major complications, systemic infections, wound infections, and cardiopulmonary complications. So that curve begins to rise fairly alarmingly once the BMI is in excess of 40 and 45. So this is why the CCGs in the UK have these mandatory BMI policies. And again, they're trying to, resource allocate, to be honest. It's not popular. The Guardian ran a good piece talking about the surgery for denying these patients is akin to racial discrimination. And an interesting paper just out from the Journal of Arthroplasty shows that it actually does cause racial, ethnic and gender disparities, with using BMI cutoffs alone reduces the eligibility for women, Black persons and Hispanic persons to access hip arthroplasty. And that, again, it is very unpopular. And it also is easy to see how the parallels in our country could happen. It's a very nuanced paper a few years back from two orthopedic surgeons: morbid obesity and total joint replacement, is it okay to say no? And they looked at it through the 4 core principles of the physician's oath. So he looked at non-maleficence. This is the obligation not to inflict harm on patients. But we know the patient's own body habitus puts them at risk in a surgical environment. We know that the problems associated with technical errors are also problematic, and they contribute to earlier revisions. The operations are longer, there's higher blood loss, there's an increased infection. So we must first not harm our patients, and putting them in an environment where they have excessive risk to surgery or increased risk of surgery, it makes it an important factor to bear in mind. In terms of autonomy, denying patients the right to go to surgery, that is an elimination of patient autonomy, and that's not okay. So we have to be fairly candid about the risks and benefits and work in a shared decision-making pathway, as Fiachra alluded to earlier on. In terms of beneficence, this is an important one as well. We have to be able to provide care to our patients that does not involve surgery alone. We have an obligation to this holistic care, unpopular as it may be among some of our tribe. Now, we know as well that connecting non-optimized patients with the appropriate resources is extremely challenging. For weight management, low glycemic control, exercise and nutritional guidance, the resources are very poorly available for that. So we must work with empowering our patients to take control of their health, because whether they have surgery or whether now or whether they have surgery in the future, that for me is a very critical part of it. And then again, as has been alluded to earlier on, there's the obligation to promote an equal distribution of healthcare. Thankfully, that's not our decision to make, but we do have to appreciate that costs are finite. What is the cost of a hip replacement for quality of life, as opposed to the costs of better managing these patients' diabetic control, heart failure, or funding for bariatric surgery, which has huge bang for buck, as we've heard from Professor Heneghan. So is it okay to say no? Well, yes, when the risks clearly outweigh the potential benefits. But, and there's a big but here, only if we supply patients with the resources to optimize their obesity prior to surgery. So it can't be no, go away. It must be no, here is the plan, how we can work towards a solution. And unfortunately, we know that the service that the HSE provides is not optimized for these patients. The massive mismanagement or the problem with demand and supply makes it extremely challenging. So we know obesity is an epidemic that is impacting on the global burden of hip replacements. We know the risk of requiring a hip replacement for osteoarthritis increases with obesity and with class of obesity. We know that hip replacement in obese patients represents a unique set of challenges, but the outcomes can be as satisfactory as their non-obese counterparts with a lot of work. We know the risks, in particular of VTE, cardiopulmonary complications, and failure by infection loosening are significantly increased, and we know the BMI cutoff levels remain extremely controversial. Thank you.
Thanks, Colin. That was excellent. We'll go on to Adrian. While Adrian's loading his slides, Stacey, how are you getting on there?
I'm just going to try again and see if it'll work. Sorry about this. I don't know why.
You're fine.
It was working earlier.
That's working. That's what I think.
Okay, Adrian's looking good there. So we might run with Adrian again. Adrian, sorry,
Yep.
Stacey, if that's all right.
Yep.
Okay, Adrian, take it away. Adrian, perhaps you might be muted still. Yeah, Adrian, you're still muted.
Can you hear me now?
Yeah, you're good. Yeah, off you go.
Sorry there. So, hi, my name is Adrian. I'm one of the orthopedic surgeons in Cappagh, Conley, and Cavan. Okay, I have no disclosures. So we all know that total knee replacement is safe and cost effective, especially reducing pain and function, improving function, sorry. The main indication is joint pain and limitation of function. We know that if we, as been said before, that we have a BMI of more than 35, there's about a threefold increase in the requirement of total knee replacement. But of course, like every surgery, if the wrong patient is chosen, there will be poor outcomes and a revision. Looking at some demographics from the registries, when it comes to patients with BMI of more than 30, about 55% in the National Joint Registry of the UK have higher BMI than 30. 59%, which is about 20% more than patients undergoing hip replacement in our own registry of Ireland. And our own data from Cappagh shows that about 64% of our patients in the past 10 years had a BMI higher than 30. And this seems to be on the increase. So what are the challenges from an orthopedic point of view? Well, there is increased technical difficulty, especially with knees. There is increased operative time. We know there's increased complications with infection, as well as aseptic loosening. And what are the preoperative challenges? Well, these patients unfortunately do have multiple medical comorbidities. They're considered to be malnourished, diabetes as well. They are inactive, which causes poor muscle mass, poor quads function when it comes to the knee, as well as poor bone quality. Most of the time, they're very difficult to medically optimize pre-surgery, and they can be a challenge for our anesthetics as well. So when it comes to technical challenges, there's multiple reports showing that there is a higher number of technical errors as well as surgeon-reported problems when performing a total knee replacement in somebody with a high BMI. And this may be related to the increased circumference of the leg. This causes the soft tissue envelope, causes difficult exposure of both the femur and tibia, limits our visualization. There is difficulty in identifying bone landmarks, whatever type of technique you use, from manual to robotic, and they do end up with longer incisions as well. Being on both sides, I guess, of the operating table, they do have a heavy leg to mobilize, and this causes difficulty for us to flex the knee and mobilize the tibia forward. And one has to take in consideration that you may require specific instrumentation, such as deeper, wider retractors for the soft tissue envelope, and also to know the weight limit of your table. When it comes to implant-specific issues, there is increasing evidence that if you use a standard tibial plate, there is a higher revision rate for aseptic loosening, and the advice is nowadays to use a standard implant, and this is across the board, which reduces your aseptic loosening. And this increases some implications as well. If you need a revision, they're more difficult to revise, you need increased instrumentation, and there is an increase in cost in using these type of implants. There's also, these patients have a long-standing OA with quite deformity and ligamentous laxity as well, which may cause imbalance in your knee replacement. And some authors are now advising even to increase the level of constraint, and which shows that there is similar outcomes to a standard constraint. This is just an example of one of my patients. Of course, I got consent for this. You have to take my word that the incision is about twice as much as I usually do. But as you notice, there is increased deformity, there is some ligamentous laxity. Implant used, there's a stem with modern cementing technique as well. And she had good outcomes. This lady was moved from one unit to the other. She was walking with a frame. At the moment, 8 weeks post-op, she's walking with one crutch. So what are the outcomes? Well, there's multiple papers on both sides. This is a paper that won the John Insel Award, which shows higher complication rates as reported by another presentations in the morbidly obese. Similar paper, same year, and joint arthroplasty in the super obese, those with BMI higher than 50. Again, higher complication rates at all levels, both systemic and local. This is a systematic review of literature published in 2019 that showed, yes, there are higher revision rates in mid and long term for total knee replacement. However, these patients had equal functional recovery to the non-obese patients. And this is another paper showing taking care of the patient-reported outcomes. And here they show that there is improved in pain, function, and stiffness across all BMIs. And it shows that they have similar benefits to patients with normal weight. This is a recent paper published this year, which shows actually that patients with higher BMI may have the greatest benefits from total knee replacement with regards to function and pain relief at 1 year. Again, Colin went through this when it comes to body mass index cutoffs. Yes, if you have a BMI cutoff, it does reduce your complication rate, but it's limiting access to a big cohort of patients that would otherwise have a complication-free total knee replacement with relatively good outcomes. Is total knee replacement cost-effective? This is just published recently again in Bone and Joint Journal, which says, yes, it is more expensive because of certain implants that we use, but yes, it is cost-effective and improves the outcomes of those patients. And this is a recent paper published in JAMA this month, which is a randomized controlled trial, which shows that bariatric surgery reduces the risk of complications after total knee replacement. But not only that, it also reduces the requirement of total knee replacement. This is a question that everybody asks, do patients lose weight? Unfortunately, the majority of patients do not lose weight after total knee replacement. And this paper only had about 6.9% of patients with lost weight. The rest were either the same or they gained weight after a total knee replacement. And so in summary, about 60% of total knee replacement done in Ireland have a BMI higher than 30. Higher BMI, it means higher complications for us. It is a more technically challenging. These patients do require a multidisciplinary approach. Bariatric surgery seems to reduce the complication rate, and maybe we should use more tibial stems and varus constraint to improve the rate of aseptic loosening.
Thanks, Adrian. So Stacey, you might try load your screen again, and in the meantime, I'm going to put a question there to Colin Murphy. If you can just turn on your monitor, Colin. And also, really, this is once again for Helen. We're getting bang for buck by bringing Helen in here as a speaker this morning. Colin, I really liked your concept. Go off and lose weight isn't an option. Go off and follow this plan. And if you do well in the plan, then yes, you have your joint replacements, but we can't offer that option. How should we as orthopods develop a pathway for to essentially bariatric surgery, or should we never see a patient with obesity, Colin? Should people get weighed by their GP and immediately streamlined into a weight management system, and then we see them? What are your thoughts on that? Because financially, it makes more sense that they're treated by Helen and her colleagues than by us first.
I agree. I couldn't agree more. It's very frustrating when often the orthopedic surgeon is the first point of contact for a patient who's in crisis mode, not only with their painful joints, but with their obesity, their lifestyle, the decision making, everything that comes with it. And it's intensely frustrating for us to try and unravel that when we've short clinic times and we're poorly equipped to deal with it. So we have the tool in our bag, which is the operation, but we're very poorly equipped to deal with anything else. And oftentimes we are accused, and probably rightly so, of poor communication skills because of that. But there's a huge deficit in terms of being able to offer the modalities that these patients need for that. That's why I was really pleased to hear about Donal O'Shea talking about the pathway of care, that this should be picked up early, that there should be GPs picking this up and referring them into services. Now, they're grossly underutilized, under-resourced, I should say, but there should be services available so that the orthopedic surgeon is an adjunct, not the primary point of contact, as we frequently find ourselves in. And that's frustrating for me, and I know it's frustrating for many of my orthopedic colleagues, that we seem to be the first and sometimes the only point of contact for patients who present in crisis like this.
Helen, have you any thoughts on that? And I see Colin will take a question for a point. Maybe he's raised his hand after Helen's spoken. You're just muted there, Helen.
Sorry, I should know by now. Yeah, I mean, the outcomes are clear that people do better when they've lost weight in terms of orthopedic outcomes, but improvements in pain. It's just the time. Can they wait long enough? If I feel responsible that we don't provide a fast enough or an accessible service to people, it's probably not fair to ask people to wait 4 or 5 years to get into a bariatric surgery program. But as Donal said, I think the medication landscape will help us to bridge that gap. So the pharmacotherapy for obesity is really excellent at the moment, particularly GLP-1 analog semaglutide, which is really well tolerated, but the issue is the cost. So I think, you know, if our model of care is funded and there was access to, you know, GPs could prescribe weight management, weight medication, weight loss medications, then at least you'd have a program for people into where, you know, just you'd say, if you're recommending weight loss, you're not just asking them to do that, but you're actually saying, can I refer you to a program that's going to help you to do this, that has multidisciplinary approach, but has access to the effective, you know, effective treatments, not just surgery, but also medications. But at the moment, cost is prohibitive for a lot of medications, which would cost upwards of 200 a month. But as a means to an end, they might be, you know, if it was a case to get to safe orthopedic surgery or to better mobility and less pain, that might be something that patients would weigh up cost benefit, you know, whether the cost of that medication would be offset by the benefits.
Colin Dunleavy.
Yeah, just so everyone has their feet on the ground here, even with bariatric surgery and really good outcomes, if somebody has come to you with a body weight of 150 kilos and you apply BMI cutoffs, and then you send them off to Helen or ourselves for outcome, they'll come back to you in 3 years' time. They may be 130 kilos. They'll still be way over your BMI point. So really just keep our focus here. Like, this is a chronic disease. This is an ongoing chronic condition for them. They will come back to you. They'll still have a high BMI. We will say they've done extremely well with their weight and they've managed their chronic disease quite well through lots of interventions. But they'll still have chronic disease, which means it's really difficult for you who, as you say, are in a stressed, busy clinic and don't have time to explore what's gone on in the past. But it is important to get there. And look, if they're fitter, if they're healthier, that's a good outcome. They will still probably need a joint replacement surgery at some stage.
I have one question for Adrian, a technical question, I suppose. Doing a knee replacement is about being able to essentially shotgun the knee and deliver the distal femur and the proximal tibia into your wound. Are there any patients where you look at the leg and you say, regardless of their BMI, I technically cannot expose the knee safely to perform my cuts, be it with enhanced technology, as you suggested, or freehand?
I think I agree, Fiachra, with you. And there is this difficulty, and it all depends where the soft tissue envelope is. Some patients have most of the soft tissue envelope concentrated at the front or at the back. When it's the back, it's quite difficult to mobilize the tibia, and it comes, if I think that there is a technical difficulty in that, I would refuse surgery, because I know there's a higher chance I'm going to cause more technical errors, and that may result in a bigger complication. But that is something that has to explore with the patient as well. Okay,
Stacey, I'm seeing white smoke there. So Stacey, we'll go Stacey, Adil, Kira, take a quick question, and then we'll finish up with Barry, Abigail. We're well behind, so we'll try and tip along as fast as we can. Thanks, though. The content is excellent, so thanks so far.
Sorry for the technical problems. I'm talking to you about obesity and spine surgery, and one of the consultants in the matter, Vincent and Cappagh. So a lot of what we've already heard. So the definition of obesity: BMI over 30 kilograms per meter squared. Obviously, we know it's an increasing prevalence in the Western world, and actually the figures show that about 60% of adults and 20% of children and young people are obese or overweight in Ireland. The majority of patients in the US undergoing lumbar spine surgery now have BMI over 25, and although we've heard it's a modifiable risk factor in elective spine surgery, but we also deal with the trauma setting. So there's an increased demand in spinal surgery in the obese patient, and we know that there's a link between low back pain and the overweight or obese patient. And there's multiple theories prophesized for this, although no one's quite sure exactly why. We believe now there's a link between the collagen 9 polymorphism and disc degenerative disease and loss of disc height. We also have the increased compressive load when in static position, and also in certain postures, there's increased pressure throughout the disc, which can lead to disc disease. Because of the increased volume of fatty tissue, we have activation of the pro-inflammatory mediators, all of which are thought to link to increasing low back pain in the elective setting. A lot of the risks we've heard about preoperatively have already been discussed today: the risk of cardiac disease, diabetes, hypertension, and COPD, which all ideally need to be optimized in the preoperative setting. But actually, as well, with the trauma setting, the sort of pre-hospital transfer and the mobilization of the obese patient is proving to be very challenging, even with loads tolerated on stretchers, ambulance ramps, actually finding collars or braces to fit patients for transfer. And we've heard as well from Helen earlier about the difficulty actually in achieving adequate imaging. And for us as spine surgeons, particularly the MRI scanner, not just from the weight load on the table, but also for the diameter. As you can see in this picture here, the states are actually now developing wider and wider MRI scanners to facilitate this. And we've had to move to some open scanning, which is not always possible. For me, predominantly the intraoperative considerations have to be taken into account. So anesthetic difficulty, again, in the elective setting, patients have to be propped to allow for ET tubing, often done in spinal surgery with fiber optics, which are challenging. The bag mask is difficult. The dose of anesthetic is difficult, and whether we should be using the total body weight or the ideal body weight for doses of medication to provide hemodynamic stability for the patient is a real anesthetic challenge. For me, a lot of my surgery is performed prone. So actually, you can see the technical challenges of proning a very large patient, both on staff, the actual manual handling side of things, but also for patient safety, so that we're not causing an increase of intra-abdominal or intrathoracic pressure. And we do know that pressure areas happen. We know that there are increased risk of peripheral neuropathies from positioning, as well as the increased abdominal pressure and increased thoracic pressure can increase the risk of epidural bleeding, from my point of view, which makes surgery much more challenging to see. Radiographic imaging is a real challenge in the obese patient. So we use a lot of fluoroscopy in theatre, and actually being able to see through the increased soft tissue is very hard. And you can see, well, just the skin folds for approaching a posterior neck can be very challenging. We also use quite a lot of neuromonitoring in spinal surgery, and actually they have a very high rate of false positives due to just actually the needle length to get down to the soft tissues as required. Postoperatively, we know, we've heard already, very high risk of surgical site infection, very high risk of VTE. There's a very high risk of reoperation or readmission within 30 days compared to the non-obese patient, and they're much slower to mobilize, which increases our surgical or hospital length of stay and obviously has cost implications. So the solutions we've kind of heard quite a lot about today. So the sort of conservative measures should be applied in all elective spine surgery. So everyone should have gone through a full conservative run with their low back pain in terms of their physiotherapy, their core strengthening, and injections, and sort of pain management, and as well as weight loss. We know that prehabilitation is very beneficial in spine surgery, with studies recently showing an increase in successful outcomes in patients who've actually undergone even just a 2-month stringent exercise and weight loss program, obviously under a guided dietitian. We're moving more and more to minimally invasive surgery, again, to reduce our risk of complications, and also a lot more navigated or robotic surgery. As you can see here, this is a navigated screw placement, which is done with intraoperative CT scans, which again tries to overcome the difficulties with intraoperative radiographic problems, hoping that we can actually avoid wrong level surgery and improve placement. And as we've heard already from Helen, bariatric surgery in the planned setting, before we go down the line of spinal surgery, has shown better outcomes. Thank you. And that's just some of the references from the stuff that we've heard.
Thanks, Stacey. Adil Menon, would you like to load your slides? Thanks. Okay, no, go ahead, sorry.
Yeah. Everybody can see my slides there?
Yes, you just need to slideshow. Thank you.
Right. So many thanks for letting me talk on today's chat today. I'm just going to go briefly over the effect of body mass index over the foot and ankle disorders in our practice. Just a brief introduction. Obesity, as we all know, has effectively reached epidemic proportions worldwide. Between 75 and 2016, the obesity rates have tripled as per the WHO, which leads to a number of medical problems, including heart diseases, diabetes, metabolic syndromes, and musculoskeletal disorders. In the United States, between 93 to 2008, there was almost 127% increase in Colles loss, which is even a greater contributor to morbidity than smoking. And in Ireland, the cost to treat the obesity related illnesses is set to reach over €2 billion by 2025. So foot pain is quite common, and particularly in obesity. Mikkel and Steele published a paper a few years ago, described that it was present in about 40% of obese patients versus just 11% of the patients in normal weight. Increased body mass is associated with poor foot function. It leads to gait alteration. It increases mechanical loads, in addition to the metabolic effects of the excess adipose tissue. Obesity leads to a number of tendon dysfunctions. Paper published by Frey and Zamora a few years ago showed that if you have a BMI of greater than 25, you are more likely to have tendon-related issues in your foot. And likewise, people or the patients with the BMI of more than 30 are at increased risk of developing plantar fasciitis, as was reported by Riddle and colleagues. And then while Junior published this paper a few years ago, saying that if that there's a higher chance of treatment failure in patients with Achilles tendinopathy, plantar fasciitis, and flat foot disorders with higher BMI. Likewise, patients with obesity are at a significantly high risk of developing acquired flat foot deformity, and there is a potential for early failure after reconstruction. However, This paper published in Foot and Ankle International, Sokop and colleagues did report similar outcomes, at least at the short term, following a reconstruction for these disorders in obese as well as normal weight patients. However, they also noticed a higher post-op complications as the BMI increased. The effects of obesity on forefoot surgery are slightly different. Chen and colleagues published this paper on it was a prospective study on 452 patients, and they observed similar improvement in the function in patients undergoing forefoot surgery, with a significant improvement in the visual analogous scale and American Orthopedic Foot and Ankle Society scores. There were no difference in the surgical site infection between obese and normal weight patients. However, there was a higher reoperation rate with the BMI of more than 30, and that was primarily due to hardware irritation, and there was some recurrence of the bunion deformity, but that was not statistically significant. Likewise, Milkarex and colleagues also reported similar outcome with no difference in pain, functional outcomes, and radiological outcomes. And Stewart et al. Showed a similar complication rate of 10 versus 9% in obese and non-obese patients. And yet again, they also noticed a higher wound-related complications in patients who are diabetics, regardless of their BMI. When we look at the hindfoot disorders, obesity does have a negative impact, in particular on the outcomes of total ankle arthroplasty, which is more and more gaining in popularity as an accepted treatment modality for end-stage ankle arthritis. Gross and colleagues published a paper on 455 primary total ankles with a minimum of 2-year follow-up. Obese patients did experience significant pain and function improvements. However, their functional outcome scores were lower than the control group. Likewise, Skipper and colleagues published on 97 total ankle replacements. And again, obese patients had a higher probability of revision and failure. In a large epidemiological study by Werner on 23,000 patients treated for end-stage ankle arthritis, obese patients had higher major and minor complications at 90 days, increased infection and DVT, and increased incidence of revision surgery. But I'll be mindful of these papers because some of these would have used older generation implants with generally a higher risk of failure and revision in those series anyway. When we look at the causes why this happens, it's both mechanical and metabolic. Obese patients have a decreased gait speed. Their pedobarographic studies would show an increased content during the stance phase by almost 45%. This results in increased peak pressure across the midfoot. This leads to avoidance of pain, which leads to further alteration in the normal gait pattern, and it creates a vicious cycle. These findings are observed both in adults as well as in obese children, as reported by Mickle and Dowling. Then we have the surgical factors. Surgeries can be more difficult in obese patients as the access is limited. It requires longer incisions, longer operating times. Excess adipose tissue can cause wound tension, can lead to relative hypoperfusion, which may decrease the delivery of oxygen and the antibiotics at the surgical incision. And then more importantly, from a foot and ankle point of view, a non-compliance with post-op weight-bearing restrictions can be really challenging, which may lead to failure of fixation or bone effusion and early failure of the implant, which may then end up with either the loss of fixation or indeed loss of bony union. Metabolic factors.
May I interrupt there? I wonder, could we move on towards your final 2 slides? And I apologize for pushing you in this regard.
Yeah, so they're just coming up there now. So the metabolic factors, as we have already spoken
I think we've covered this. Maybe you just super. Thank you.
So in conclusion, the effect of obesity in foot and ankle pathology is multifactorial. The biomechanical reasons predominate. However, metabolic factors are equally important. And the obese patients tend to have worse functional scores pre-operatively and the comparable post-operative outcomes. However, there is a higher surgical risk of complications. The take-home message really is that we need to have a frank discussion with the patients regarding the setting up the realistic expectations, both during the perioperative phase and in the post-operative course. And every effort should be made to optimize the health pre-operatively to reduce the post-op complications. Thank you.
Thanks, Adil. We'll move on to Ciara, then Barry, and Abigail's talk we're going to upload for later viewing. Unfortunately, we won't have time for questions now at the end. But the speakers can answer the questions in the toolbar.
Okay, morning guys. Thanks very much for this opportunity to talk about the kiddies. So some of the stuff we'll already have looked at. Anyone who's familiar with kids, I know that they have their own kind of little graphs in terms of where they are. And really it's all this section up on the top here where the obesity is. These are 2020 figures. So at that stage, what we could see in Ireland, that there was a decreasing trend in obesity, which is unusual. However, when they split that out a little bit more, what you find is in the more advantaged schools, that things are improving, but in the disadvantaged schools, high or overweight and obesity is actually increasing, and that will become a bit more relevant when we look at some of the conditions that for kids later. So really, I suppose one of the most important things in terms of kids is that by the age of 2, you've got 40% of your bone density, and by the age of 18, you should have 90%. And there's 2 populations of kids that I'm worried about for the future for my adult colleagues, which are I need to fit into my size 4 jeans, restrictive diets, but also the central obesity. I don't get any exercise, my diet is awful, kids, because neither of them will have good bone stock, okay? We've looked a little bit through some of the metabolic things associated with it already, so I'm not going to go through this, but I think what's important that you can modify is the calcium homeostasis can be off, the vitamin D can be off because of the diet, but also because vitamin D is fat soluble, so it can actually be sequestered in the fat in these kids, and also because their hormonal balance is off. Even though these are kids who often mature early and are the tallest in the class when they're 10, they'll be the ones with the short stature and the early closure of physes, which doesn't allow them to remodel stuff out over time as well. So they're a little bit unusual. Leptin is the big thing that's been described in the pediatric literature as being the problem. As you can see, it's supposed to do a whole lot of things. I'm not going to go into any detail because I think we covered it a little bit, but it acts through the RANK-L and the RANK-LB pathway that we all would have known so well for osteoporosis. And again, whereas these kids have large bones, their cortices are smaller, and that's got to do with the interaction with leptin and osteoblasts, and their relative bone mineral density to the rest, the size of their body is incorrect and less. So they are people that you need to think about. In terms of trauma, as Adil mentioned, they walk differently. They have slower speed step. They have a broader based gait, and they're more likely to fall. And when they fall, they're more likely to have, obviously, per body mass, they have a higher impact. So they have increased severity with the problems. They're more likely to injure the physis in the lower limb than non-obese children. Again, it's probably got to do with their hormonal imbalances. A lot of their fractures are evolving towards adult fractures, and what I mean by that is that you get a lot of early physeal closure, so it's not unusual in a heavier child to see a T intracondylar fracture that you'll have to treat with like plates like you would an adult, as opposed to wires as you would with most of the other supracondylars. In lower in RTAs, they have more lower extremity injuries, and a lot more of them need operative treatment. So I think of the operative treatment, it's like the classics, the lady with the fractured humerus, the can't be married in the brace, and it comes back to the good old basics of pediatric orthopedic management, which is a good, well-fitted molded cast will manage a lot of pediatric fractures that would otherwise require intervention, and you want to get your cast index down low, but it is incredibly difficult to get a good cast index on an arm that has a lot of soft tissue surrounding it in common with everyone else. In terms of the post-operative complications, Ironically, the bed days are actually equal to the non-obese children, but they do have higher rates of everything else, as you can imagine. And I just wanted to flag up DVTs because it's something that you really don't think about an awful lot, but probably because these children are more hormonally advanced, if they're kind of post-pubescent, they're almost like an adult, and there are pediatric guidelines with the anesthetics. And just have a look that if you have 2 risk factors that you should consider low molecular weight heparin, and being obese gives you 1 straight away. So once you're obese and you've got something in the lower limb, you should at least consider it. And there is that published guideline if people want to look at it, because it's not something that in pediatrics we think about a lot, but once they're over 13 and hormonally mature and obese, you do need to start thinking about it, because they are the ones who will get the DVTs. And we'll do a very, very short run through some of the different fractures. So again, like I said, around the elbow, you're 4 times more likely to require an open reduction if it's supracondylar. And their rate of pre-op complications in terms of nerve damage is more, and same with post-op wire problems, which again is very understandable in terms of the ability to handle the soft tissues, but also kind of having a big fat layer between your bone and kind of mobile soft tissue, and also a higher rate of varus malalignment. The other thing that has been noted in some studies is that they have a higher rate of lateral condyle fractures in the obese children. And the theory behind that, again, is that when they fall, they're often quite deconditioned in terms of their their ability for exercise, etc., and their fitness level. So they're just not quick enough to get their arm out for a full outstretched arm to get their supracondylar fracture, and so they fall with the arm partially bent, and that's how they end up with a lateral condyle fracture. They're also more likely with the lateral condyle fracture to have a highly displaced one, and again that puts them into the group more likely to be need to have an open reduction, and again for the minimally displaced ones, incredibly difficult to try and find it. Perthes. So the classic Perthes description was the small skinny child, and usually if when you think about it, it was from like the lower social economic groups, so not with a healthy diet. And this is now being born through with the higher level of higher weight kids in the lower social economic groups. And so it's more likely now to be associated with obesity than it was, and also hypothyroidism. So again, if you're seeing these kids, maybe to think about doing a set of bloods. Back to the leptin again. So the leptin, they've looked at in relation to its relationship in obese kids to both the lateral pillar classification and the Stuhlberg classification, which is your outcome. And in both, it's related to the severity of the head collapse. And then just like the importance of studies like this, and there's another one that I haven't included, but they are starting to look again at kind of ways that you can treat these other than just surgically, but medically, try and modify your factors pre-operative or perioperatively. SUFI, absolutely. We've always thought it was that, again, that prepubescent, chubby child, not always, but definitely there is a higher risk. And they did a lovely study in Scotland, seeing as what we were talking about Scotland, where kids who were obese at the age of 5 to 6 had a 5.9 times higher risk of a SUFI, whereas those in the 11 time had 17 times higher of getting a SUFI when they looked at. And this is a really large population study that they looked at. Then you're into all the complications, including hardware breakage, because that's a very small screw to be managing a very large weight capacity. And then the final one, I suppose, that's familiar is Blount's, and definitely for the infantile ones, that the hypothesis is because of the obesity, because they tend to be more obese, and definitely for the adolescent, that 90% of the adolescents will be obese. It's got to do with an altered biomechanical stress on the physis of the proximal and posterior tibia, just because of the way you get the varus thrust, and that's what gives you your pathology. And again, these are people who, although there is surgery for them, they still end up with difficult knees that will go on to give people problems in the future. So my quick summary for the end of it is, even though, and I'm totally with Colin on this, like we are all in busy clinics and busy fracture clinics where we're often the pediatric fracture is the kind of the straightforward one to kind of get through the clinic. But it is like an opportunity for a very 2 or 3 sentence intervention. And that would be if you've got operative cancer, the risk of failures, if they're slow to heal, the vitamin D, and just be aware of your increased perioperative complications. And then sometimes people ask, what's the dose of vitamin D? So what I would say to you is there's no official dose for if you haven't gone to the bother of checking the vitamin D levels, which we often don't because it takes them so long to come back. The child is gone at that stage. But most supplements will give about 50 to 100% of the recommended daily dose. The actual treatment dose for a vitamin D deficient is somewhere between 8 and 25 times the daily dose. So I usually tell any of the parents where there's any doubt to double or triple up the dose of what they have, or to talk indeed to their health shop with it. And then, yeah, I suppose I messed up my slides. Quick intervention at fracture clinic, encourage activity at least 60 minutes and the healthy diet. And I do think from a pediatric point of view, this is something that should be managed in the community. This is an ongoing process with these. It will often be a familial thing. They're kids and families that need help. So I do think a letter to the GP is appropriate, and that's where it should be directed. And if you have an inpatient with obesity and you are very concerned, I would link them into the peds and do their blood sugar level, blood pressure, which is often off in about 13% of them, and their thyroid screen. And after all that, for all the years that I dreaded, I would say bring back the trampoline and get them all out on it in age size matched groups. Thank you.
Well done, Ciara. That's excellent. 3 really good points there: DVT prophylaxis, vitamin D, and the opportunity for intervention. So I think they're really good take-home messages. Thanks, Ciara. Barry.
Yeah, I'm right here. Thanks very much, everyone, for the opportunity to talk. Hang on. Why can't I see my own screen here? Sorry, Fiachra, I'm trying to bring up my talk.
Ciara, will you stop sharing?
I need to stop sharing. TMI.
Okay. Thanks, Ciara. Okay, so I'm going to rush through this quickly.
Hi, Barry. I'm so sorry to interrupt. It's Helen in the control room. Just to let you know, we have really gone over the time now, and we're very late in launching the next session. So I do really apologise. We don't have time to go ahead. What I can offer as a backup, Barry, I know we haven't got to see your presentation. If you would like to record that, then we can put that on for the delegates to view. I'm really sorry, but hopefully that's okay as a compromise.
Helen, what I might do is I might send a Zoom link to Barry right now. Barry can present to me and I can ask him questions, and then I'll send that recording to you and we'll add it to Abigail's at the end. I'd have to thank everyone for their talks today. We've covered so much, and I think as an institute in orthopedics, we have an opportunity now to make some health policy recommendations in conjunction with Donal and Helen, and perhaps really make an effort on trying to address the issue that we have for patients with obesity. Thanks very much to everyone, and Barry, I'll send you a link now shortly, okay?
No worries, Fiachra, thanks.
Okay, Barry O'Neill, consultant orthopedic surgeon at Sligo University Hospital. Many thanks for your talk on obesity and trauma as part of the Chartered A series.
Okay, Fiachra and John, thanks very much for the invite. I really appreciate it. So just going to start off with a study from the Edinburgh group, which published an epidemiological analysis of all of the patients reporting to Edinburgh Royal Infirmary over a 12-month period. And they looked at the BMI for all of those patients and also the fracture classification. And the aim of the study was to identify any fractures or indeed fracture patterns that were directly associated with obesity. And obviously they're ideally placed to do this because, as we all know, UK residents have the highest rate of obesity in Western Europe. And what they showed was that the prevalence of obesity in Scottish males and females by age group, i.e. the solid line, and then they showed the lower incidence of obesity in the fracture population for both groups. So basically, the incidence of obesity is higher in the general population than it is in those with fractures. And so they've shown that patients with obesity are not more prone to fracture. They also showed that there's certain fracture patterns which do relate to obesity. And in males, it's the proximal humerus fracture, the finger phalangeal fractures and ankle fractures. In females, it's the diaphyseal humeral fracture, carpal fractures, and again, ankle fractures. But they concluded that these differences are as much to do with behavioural differences as they are to do with the obesity itself. And the only common feature really was that ankle fractures are more prevalent in obese individuals. And this has been shown previously in other studies. And it's also been documented previously that obesity increases the severity of ankle fractures and also those of distal radius fractures. But I suppose the more important question with regards to obesity, rather than just, which fractures are affected, is does obesity adversely affect the outcome in trauma patients? Or is there an advantage in having sort of additional protection over the bones and additional energy stores for the recovery period after your fracture? And this all comes back to the obesity paradox, which is a theory that first came to prominence in 1999, and it's kind of popularized as reverse epidemiology by Dr. Kalantarzadeh, who's an Iranian-American physician, mostly in the nephrology and cardiology papers in the 2003-2004. And it basically states that obesity may counterintuitively be protective and associated with greater survival in certain groups of people, such as elderly individuals or those with certain chronic diseases. Now, there are many critics of this theory, and much of the supportive research has been shown to be inherently flawed. And one of the most damning criticisms of the original research is the fact that it was heavily sponsored by the Coca-Cola company. So we'll just sort of move on from there. A recent study of critically ill ICU patients in Switzerland has shown that an elevated BMI is associated with a lower risk of hypoglycemia, a higher incidence of hyperglycemia, and a lower mortality rate. And this is thought to be as a result of the increased energy stores that are available for metabolism in the sort of post-injury period. And they identified, Dvorak's paper from Chicago in 2020 looked at the mortality rate in relation to BMI in young adults identified as having sustained orthopedic trauma on the US National Trauma Database. And they identified statistically significant differences in mortality rates between those with a BMI between 18.5 and 34.9, and those with a BMI that was higher or lower than these, in inverted commas, normal values. So they've described the U-shaped curve with the outliers for BMI demonstrating a longer length of stay in ICU and a higher use of resources, finances, but also a significantly improved survival rate as the primary outcome measure. So according to these authors, if you don't have a normal, again in inverted commas, BMI, you've got a better chance of survival. But what is normal? And can it be determined simply by calculating the BMI? We often think of malnourished individuals as being thin, underweight, unhealthy, but the American Society for Parenteral and Enteral Nutrition describes malnutrition as a state of nutrition in which a combination of varying degrees of overnutrition or undernutrition have led to changes in body composition and diminished function. So Hachimoji's paper from Philadelphia in 2019 showed the opposite of the Dvorak paper, and they conclude that obesity is significantly related with mortality, and that morbidity most commonly occurs via thromboembolic, respiratory, and infectious complications. And their paper looked at all of the trauma cases in Pennsylvania, not just orthopedic trauma cases, so general surgery and vascular and all included, but the results are still noteworthy. And the table here shows that there's a significantly higher incidence in DVT, in aspiration pneumonia, in wound infection, acute kidney injury, and ARDS in obese patients. But what I found interesting was, despite the significantly higher incidence of DVT and ARDS in obese patients, the incidence of pulmonary embolism was actually lower in these patients, although in fairness, this finding was not statistically significant. Bell's study from Indiana in 2017 showed a significant increase in cardiovascular and respiratory complications in obese patients when compared with non-obese patients. And what I found interesting from this study, apart from the findings, was the fact that they used the term non-obese patients as opposed to normal patients, which seems to be what most of the other studies have used. And the graph here shows that Bell et al. Recorded approximately double the percentage of these patients who developed ARDS, DVT, and PE when compared with non-obese patients. And remember that the Hachimoto's study showed the direct opposite result for pulmonary embolism. So the incidence of unplanned intubation was almost double for these obese patients as well in the study. So why would obese patients have a worse prognosis than normal or non-obese patients in the context of trauma? And I think it comes down to the adverse effect of hypoalbuminemia as a marker of malnutrition, and obesity in orthopedic patients is well established. So most of this work has been carried out in patients undergoing elective procedures or elderly patients with negative femur fractures. But this particular study from Texas in 2020 looks at these factors in young adults undergoing IM fixation of femoral fractures, and it has shown that hypoalbuminemia is associated with older age, higher ASA score, and female gender. Obesity is also associated with older age and a higher ASA score, and they've also shown that the rate of wound complications is significantly higher in obese patients. So just to summarize all of that, I suppose, obese people are not more prone to fractures than non-obese people. Certain fractures are more common in obese people, and there are gender differences. Obesity increases the severity of ankle fractures and distal radius fractures. The obesity paradox has not been proven in trauma, and my gut feeling is that it doesn't exist. But obese patients are at higher risk of post-traumatic complications, mostly cardiovascular, respiratory, and infectious complications. Thanks very much for your time. I appreciate you listening to me.
Thanks, Barry. I have a question about how we manage trauma for patients with obesity. So are there situations now, Barry, where you look at a patient with a particular fracture that in the person without obesity would be an obligate operation, an intra-articular fracture that we need to get anatomical reduction on, for example? Are there now situations whereby you're presented with a patient with obesity with a fracture that in the past you'd treat surgically, that you are now saying, well, maybe in this case, I'm going to treat you non-operatively? Is that something that comes into your treatment algorithm?
Well, as with any sort of trauma, you have to treat every fracture in every patient on an individual basis, and you have to balance your pros and cons. And I suppose, going back to the point that Ciara made previously, it's sometimes more difficult to treat fractures in overweight or obese patients non-operatively because of the difficulty, as Ciara mentioned in her context, of the CAST index. So sometimes, contrary to what you're actually asking, you have to go in and fix these fractures because it's very, very difficult or nigh on impossible to treat them non-operatively in a sling or a cast. Body habitus can, affect your ability to do that. And I suppose the classic example is the midshaft humerus fracture in the overweight, or pardon the phrase, the large-breasted lady, whereby essentially the fracture is hinging on the body habitus and it's impossible to keep it under control. So there, in some circumstances, you're almost obligated to operate in order to gain the sort of control of the fracture that you want to allow it to heal.
For patients that you treat with or without an operation, but need a period of immobilization, are you being more aggressive, if you like, in your thromboprophylaxis management, or not?
I'm not, but I take your point, and I probably should be. It's something that all of us, and I suppose speaking as a trauma surgeon, particularly trauma surgeons, don't really think about as much as we should. And I do take the point that yes, that is a consideration that we should be taking into account much more often than we actually do.
One final question, and this is probably anecdotal, Barry, but with the increased body mass and the increased energy going across bones, are you seeing more comminuted fractures more extensive intra-articular fractures, or no real difference between the patient with obesity and the patient with normal body mass?
Well, the research shows that obese patients tend to have more severe fractures within the distal radius of the ankle. And again, it's the loading effect. In the ankle, it's the fact that there's so much torsional force going through the ankle. And in the distal radius, it's more to do with the load going through when the patient hits the ground, I suppose. Other than that, I suppose I'd have to go back to basic principles, that a fracture is just a soft tissue injury, which is complicated by the presence of a broken bone. So in actual fact, in obese patients, and again, as you said, this is anecdotal, I would imagine that a lot more of the energy is actually absorbed by the soft tissues. And whilst that may be good for the bone, it's not necessarily for the overall outcome, because let's say you're stabilizing the bone in order to protect the soft tissues. So if the soft tissues have taken much more of an insult, then you're at a much higher incidence, or a much higher risk, sorry, of developing complications within that. So it's about thinking about it sort of almost the other way. It seems almost counterintuitive, but yeah, if you've got a sort of less comminuted, less severe bony injury because of the level of soft tissue enveloping the bone, you really have to be thinking more about what's actually happened to the soft tissues rather than the bone, I suppose.
Okay, thanks, Barry. We're going to stop there and move on to Abigail Walsh, consultant anaesthetist, St. Vincent's University Hospital, Dublin.
Good morning. So I've got a very brief slot here, so I'm going to focus on quite a narrow area of anesthesia. So I thought I'd talk predominantly about patients who are obese with sleep disordered breathing and their risk of, and how to mitigate their risk of, post-operative respiratory complications. So sleep disordered breathing encompasses both obstructive sleep apnea and obesity hyperventilation syndrome. The latter is the most severe form of the disease. Both are diagnosed by sleep studies and on the basis of the number of apneas or hypoventilation episodes that occur per hour whilst asleep. That's the AHI, or apnea hypoventilation index. 70% of those with OSA are obese, and nearly half of all obese patients have OSA. So this is a common problem. And these patients have a markedly increased risk of post-operative complications, specifically heart failure, respiratory failure, unplanned ICU admission, and increased length of stay. So to get an idea of when and where these complications happen, I think it's interesting to refer to this study, which was published a couple of years ago in one of the big US anesthesia journals. It was a 20-year retrospective review of legal databases in the US, where between 15 and 20,000 medical malpractice lawsuits are brought against doctors annually. They selected out all cases of serious adverse post-operative outcomes directly related to obstructive sleep apnea. Surgical complications like uncontrolled bleeding, etc., were excluded, and the adverse perioperative outcome had to result in a lawsuit that was then adjudicated in a court of law. So they came up with 24 cases, which included death, anoxic brain injury, or upper airway trauma, which was chronic aspiration problems or else permanent tracheostomy, all related to obstructive sleep apnea. And two things are highlighted: that opioids were implicated in all the cases involving a patient with obesity and sleep disordered breathing, but also the location of the adverse event I think is interesting to comment upon. So if I could draw your attention to the circled numbers on the right-hand side, this depicts the location of where the adverse event happened. So the first number, 5, is the intraoperative. PACU is a third of cases, 33%, but in just under half of these complications, 46% of them occurred on the surgical ward. So these do not necessarily, or these cases are not necessarily seen in theatre by an anaesthetist. They present on the surgical wards post-operatively. So it highlights really how important it is to choose the correct location and level of care for these high-risk patients. So what are the factors that contribute to this? So this slide depicts some of these. It's intuitive to think that excessive fluid administration and edema will exacerbate OSA by edema collecting in the pharyngeal spaces. Similarly, the direct respiratory depressant effect of opiates is not surprising. What I think is interesting is the influence of opioids on sleep architecture. So opioids reduce REM sleep, and REM sleep is the phase at which muscle tone is at its lowest, and so OSA symptoms worsen. So you have a situation where initially there is less REM sleep in the first 24 to 48 hours post-op when analgesia requirements are at their greatest. However, the brain needs to address this deficit of REM sleep, and there's a rebound in REM sleep when opiates are tapered. And so this is the period at which the patient can have an increase in their apnea hypoventilation index and a worsening in their OSA symptoms. And classically, that's described as happening on day 3 post-operatively, in the night of the 3rd post-operative day. And finally, we have CPAP therapy for obstructive sleep apnea and its influence on post-op complications in this group. Studies would suggest that diagnosing OSA and starting CPAP preoperatively reduces apneic events post-operatively in these patients. There's also a trend towards a reduction in length of stay and in reduction in rates of pneumonia post-operatively when CPAP is used appropriately pre and post-operatively. So in conclusion, I think the most important things are that there's a diagnosis of obstructive sleep apnea made and CPAP therapy is started preoperatively if it is thought to be appropriate. And then post-operatively, intuitively enough, restricting fluids and minimizing opiates where possible is important. But probably the most important of all is choosing the correct location for these patients. And I'm generally guided by their BMI and the severity of obstructive sleep apnea as indexed by their AHI, if that's available. So if it's over 30 apneic episodes an hour and the patient's going to need IV opiates, then really a HDU is the best place for the patient's care. If it's more moderate or mild OSA and oral opiates will suffice, then oximetry on a surgical ward, I think, is appropriate in most cases. So thank you for your time. And if you have any questions, please feel free to email me. I'd be delighted to answer those.